Hello, I am Dr. Dale Rose, Deputy Director of the Division of Bacterial Diseases for the National Center for Immunization and Respiratory Diseases, or NCIRD, at the Centers for Disease Control and Prevention, or CDC. I will be the moderator for this session, and I am delighted that you are participating in the 2025 CDC Training for Vaccine-Preventable Disease Surveillance. The 2025 course is presented in 2 sessions. During this session, we will cover Bacterial Vaccine-Preventable Diseases, or VPDs. The viral VPDs will be covered in a separate session. For those seeking continuing education credits, please follow the directions at the end of this session. You must register on CDC Train to receive continuing education credits for this course. CDC, our planners, and content experts wish to disclose that they have no financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept financial or in-kind support from any ineligible company for this continuing education activity. In this session, we will cover meningococcal disease, invasive pneumococcal disease, Haemophilus influenzae, tetanus, pertussis, diphtheria, and surveillance indicators. The Manual for the Surveillance of Vaccine-Preventable Diseases, which includes many disease-specific and cross-cutting chapters, will serve as the text for this course. Throughout this session, subject matter experts may make reference to specific chapters or appendices found in the manual. The 8 objectives for this update are to identify the 3 main levels of the National Surveillance System for Vaccine-Preventable Diseases, describe the concept of surveillance indicators, discuss the importance of case identification for surveillance, describe appropriate mechanisms for surveillance, describe the appropriate application of case definitions, including clinical description and case classification, list the most appropriate laboratory tests for surveillance, list epidemiologically important data to collect for surveillance, and describe one way that this educational activity will improve contributions as a team member. At this time, we will discuss meningococcal disease presented by Amy Rubis. Mrs. Rubis is an epidemiologist with the Division of Bacterial Diseases for the National Center for Immunization and Respiratory Diseases at the Centers for Disease Control and Prevention.
Thank you, Dr. Rose. I appreciate the opportunity to discuss meningococcal disease during this training. National surveillance is important to characterize the burden of meningococcal disease and to evaluate changes in the epidemiology of meningococcal disease over time. Surveillance data are used to monitor the impact of meningococcal vaccines, to guide public health policy, and develop prevention and control strategies. Laboratory surveillance to monitor the molecular epidemiology of Neisseria meningitidis is also important. Before I discuss the components of surveillance, let's go through some background information about meningococcal disease. Invasive meningococcal disease is a serious, rapidly developing, and potentially fatal infection. Meningococcal disease typically presents as one of 3 clinical syndromes: meningitis, a bloodstream infection called bacteremia, or bacteremic pneumonia. Initial symptoms are often nonspecific and include nausea and vomiting, stiff neck, and fever. However, invasive meningococcal disease progresses rapidly and can result in a life-threatening infection within hours. Most disease occurs in previously healthy people, which makes this illness particularly devastating. The child shown here has a severe form of bacteremia with purpuric rash. Even with prompt and appropriate treatment, morbidity and mortality are both high. Approximately 10 to 15% of cases are fatal, and 10 to 20% of survivors have serious long-term sequelae. These can include brain injury, limb amputation due to necrosis of the extremities, hearing loss, and reduced kidney function. The bacteria spreads from person to person through close contact with respiratory or oral secretions from ill people or more often from asymptomatic carriers. When a case is identified, rapid treatment is crucial and antibiotic prophylaxis is recommended for close contacts of patients with invasive meningococcal disease to prevent secondary cases. Neisseria meningitidis can be classified into serogroups based on the chemical composition of the polysaccharide capsule. 12 meningococcal serogroups have been identified, with 6 serogroups A, B, C, W, X, and Y accounting for almost all cases of invasive disease worldwide. Serogroups B, C, and Y are the major causes of meningococcal disease in the United States. The proportion of cases caused by each serogroup changes with time and varies by age group. The risk factors that influence the development of meningococcal disease fall into 3 broad categories. The first is pathogen virulence factors, including the polysaccharide capsule mentioned earlier. There are also host factors that affect whether someone develops invasive disease. People with complement deficiencies, people who are asplenic, and people with HIV are at higher risk for meningococcal disease. And finally, there are population and environmental factors that influence risk, including factors that increase exposure and factors that influence the health of the nasopharynx and the body's ability to prevent invasion, like active or passive smoking and having an upper respiratory tract infection. Meningococcal disease incidence in the U.S. declined dramatically between 1996 and 2019, with further declines in 2020 and 2021. In 2022 and 2023, however, we've been seeing a rebound. Based on preliminary data for 2023, we had 425 cases, which equates to the highest incidence we have seen since 2014. This figure shows incidence by serogroup over time, and you can see that serogroup Y is driving the increase in incidence in 2022 and 2023. This figure shows the incidence by age group and serogroup from 2014 through preliminary 2023 data. Serogroup B is shown in blue, serogroups A, C, W, and Y are shown collectively in yellow, and cases with other or unknown serogroup are in gray. Incidence and serogroup distribution vary by age group, with the highest incidence observed in children less than 2 years of age and adults greater than 85 years of age. A peak in incidence is also observed among adolescents and young adults 16 to 20 years of age. Serogroup B is the predominant serogroup in children less than 5, and in adults greater than 20 years of age, serogroups C, W, and Y cause the majority of disease. The number of ciprofloxacin-resistant cases has increased in recent years. Jurisdictions seeing ciprofloxacin-resistant cases should consult guidance available on the CDC meningococcal webpage and in MMWR. Links to these resources are shown on the slide. This guidance is intended to help health departments decide when to discontinue use of ciprofloxacin for prophylaxis of close contacts of patients with meningococcal disease in areas with ciprofloxacin-resistant cases. 5 meningococcal vaccines are licensed and available in the United States. There are 2 quadrivalent meningococcal conjugate vaccines that protect against serogroups A, C, W, and Y, referred to as MenACWY vaccines. Of note, Menactra is no longer available for use. 2 recombinant protein serogroup B meningococcal vaccines, which we will refer to as MenB vaccines, are licensed and available in the U.S. Both MenB vaccines are approved for use in persons 10 through 25 years of age. 1 pentavalent MenABCWY vaccine is also available that is a combination of a previously licensed MenACWY and MenB vaccine. A second pentavalent vaccine is in development. The current MenACWY meningococcal vaccine recommendations from the Advisory Committee on Immunization Practices, or ACIP, are: first, routine vaccination of all adolescents aged 11 to 18 years, with the first dose given at 11 or 12 years, and a booster dose at 16 years. Second, routine vaccination is also recommended for children at least 2 months old who are at increased risk for meningococcal disease, and also people with certain underlying medical conditions, occupational exposure to Neisseria meningitidis, college freshmen living in residence halls, military recruits, and those who travel to or reside in countries where meningococcal disease is hyperendemic or epidemic. Finally, vaccination is recommended for people who are at increased risk during a meningococcal disease outbreak. For MenB vaccines, those recommended to receive vaccine include children at least 10 years old at increased risk for meningococcal disease. Similar to the MenACWY recommendations, but a little narrower, these recommendations also include people with complement deficiency or asplenia, microbiologists, and people at increased risk because of a serogroup B meningococcal disease outbreak. ACIP does not routinely recommend MenB vaccination for adolescents, but does recommend that adolescents and young adults 16 through 23 years of age may be vaccinated with a MenB vaccine to provide short-term protection against most strains of serogroup B meningococcal disease based on shared clinical decision-making. In the United States, meningococcal disease is nationally notifiable. States report cases to CDC as part of National Notifiable Diseases Surveillance System, or NNDSS. NNDSS includes case data from healthcare providers and laboratories in all 50 states, New York City, and Washington, D.C. In addition, active surveillance for meningococcal disease is conducted by active bacterial core surveillance, or ABCs, in 10 sites. In addition to NNDSS and ABCs, in 2015, CDC implemented enhanced meningococcal disease surveillance through the Epidemiology and Laboratory Capacity, or ELC, VPD surveillance project. The goals for enhanced meningococcal disease surveillance are to collect more complete data at CDC for key variables for monitoring meningococcal disease epidemiology and informing vaccine policy decisions, and to collect meningococcal isolates from all meningococcal disease cases. Data and isolates are now being routinely collected from all state health departments and several large jurisdiction health departments. Meningococcal disease cases are confirmed based on isolation of the organism from a normally sterile site or from purpuric lesions. A diagnosis based on culture is quite specific, but not all cases are culture confirmed, especially in patients who have already received antibiotics. Meningococcal cases can also be confirmed based on detection of Neisseria meningitidis specific DNA in a specimen obtained from a normally sterile site using a polymerase chain reaction, or PCR test. Probable cases include those with some laboratory evidence of Neisseria meningitidis, but where the case cannot be confirmed by culture or PCR. A probable case is defined as detection of Neisseria meningitidis antigen by immunohistochemistry on formalin-fixed tissue, or latex agglutination of cerebrospinal fluid, or CSF. Latex agglutination testing is available at some hospitals and state health departments. Immunohistochemistry testing is only available at CDC. Information that should be collected for a case of meningococcal disease includes demographic, clinical, and risk factor data. Serogroup and vaccination history are also important data to report. Testing should be performed to determine the serogroup of the isolate because vaccination can be used to control outbreaks caused by serogroups in the vaccines. Serogroup testing of Neisseria meningitidis isolates is performed at most state public health laboratories. Surveillance will be critical to monitor the increases in meningococcal disease being observed.
Thank you, Amy. This concludes the meningococcal disease section of this training. We will now be joined remotely by Ryan Gierke to discuss invasive pneumococcal disease. Mr. Gierke is the pneumococcal coordinator and an epidemiologist with the Division of Bacterial Diseases for the National Center for Immunization and Respiratory Diseases at CDC.
Thank you, Dr. Rose. Today we are discussing the surveillance of invasive pneumococcal disease. Pneumococcal disease is caused by the bacterium Streptococcus pneumoniae. It's a leading cause of bacterial pneumonia, meningitis, and bacteremia worldwide. Groups at increased risk for pneumococcal disease include children under 5, older adults, and persons with chronic or immunocompromising medical conditions. Invasive pneumococcal disease, or IPD, is defined as pneumococcus isolated from a sterile site, like blood. It is a less frequent but more severe form of the infection. In the United States, IPD causes an estimated 30,000 cases and 3,000 deaths each year. There are over 100 distinct serotypes of S. pneumoniae. However, serotypes vary in their ability to cause disease. The objectives of pneumococcal disease surveillance in the United States are to measure the burden of IPD among persons of all ages, to characterize national and local IPD trends, to track possible emerging antibiotic resistance, to evaluate the impact of pneumococcal vaccines on disease burden, and to inform future vaccine development. There are 2 different types of pneumococcal vaccines available. A polysaccharide vaccine, which covers 23 serotypes, referred to as PPSV23, has been in use since 1983. And conjugate vaccines. Both types of vaccines protect against serotype-specific disease, but conjugate vaccines create a greater immune response. The first conjugate vaccine, covering 7 serotypes, called PCV7, was introduced in 2000. This was replaced by PCV13 in 2010. 3 new higher valency vaccines have been introduced in the past 3 years. PCV15 and PCV20 are in use in both children and adults, and PCV21 was recommended for use in adults in 2024. Monitoring the impact of these new vaccines on IPD rates is crucial. U.S. data on IPD are obtained from 2 surveillance platforms. One platform is CDC's Active Bacterial Core Surveillance System, or ABCs. ABCs is active population-based surveillance of IPD at 10 sites across the U.S., representing about 10% of the U.S. population. Around 90% of case isolates are obtained for both serotyping and antimicrobial susceptibility testing, or AST. The other is the Nationally Notifiable Diseases Surveillance System, or NNDSS. U.S. jurisdictions report cases of IPD through this system. In addition, there are optional projects for jurisdictions to perform enhanced IPD surveillance. For jurisdictions that participate, efforts are made to obtain the isolates for IPD cases less than 5 years of age for serotyping and AST, and to obtain the case's vaccination history. Today, we'll look at recent IPD trends using data from ABCs. This graph shows rates of IPD from 2007 through 2022. The vertical axis shows incidence expressed as cases per 100,000 persons. Adults aged 65 years and older, shown in the dark blue line, have the highest rates of IPD. Rates of IPD in children aged less than 5 are shown in gray. After introduction of PCV13 in children in 2010, rates of IPD in children aged less than 5 declined sharply. Rates of IPD also declined in adults due to the indirect effects of vaccinating children. These declines plateaued around 2014, and rates remained relatively stable through 2019. No additional declines in IPD were observed after PCV13 was recommended for adults aged 65 years and older in late 2014. In 2020, during the COVID-19 pandemic, rates of IPD declined by 50% in both children and adults compared to 2019. In 2021 and 2022, rates of IPD began to rebound. The rapid changes in IPD rates during COVID and the recent introduction of new higher valency vaccines highlight the importance of continued IPD surveillance to monitor trends. Although ABCs provides detailed information on IPD cases from 10 areas of the U.S., it cannot provide information on the impact of each state's pneumococcal conjugate vaccine program. Nationally notifiable diseases surveillance data is important for that purpose. IPD cases in people of all ages are nationally notifiable. Confirmed cases are defined as isolation of S. pneumoniae from a normally sterile site. Probable cases are cases of invasive disease detected only by culture-independent diagnostic tests, or CIDTs. For each IPD case identified, there are core data that should be collected. These include demographic information, clinical data, vaccination history, and risk factors for invasive disease. Examples of risk factors include smoking, alcohol abuse, and underlying medical conditions such as diabetes. A full list of risk factors is available in the link in the footnote. When possible, it is important to serotype isolates for IPD cases. Without serotype information, it is much more difficult to determine the impact of serotype-specific pneumococcal vaccines and to identify potential serotypes for use in future vaccines. It's also valuable to obtain antimicrobial susceptibility testing, or AST, for IPD isolates to monitor antibiotic resistance. There are several options available for jurisdictions to perform serotyping and AST. State public health labs, clinical, and commercial labs can use polymerase chain reaction, or PCR, for serotyping. CDC has developed a protocol to identify pneumococcal serotypes using PCR. We have included a link to the protocol on the resources page at the end of this presentation. Phenotypic serotyping can be performed by quelling, and whole genome sequencing can be used to predict serotype and antimicrobial resistance patterns. If states are unable to perform serotyping or AST, two reference laboratories, which are part of the CDC-funded Antimicrobial Resistance Laboratory Network, or ARLN, can assist states with CLIA-approved serotyping and AST for IPD isolates that meet certain criteria. Links with information on testing through ARLN are included in the resources page. Additionally, CDC Streptococcus Laboratory can assist with non-CLIA serotyping of potential outbreak isolates, and AST can be performed for isolates with unusual resistance features. Contact information for CDC outbreak and testing assistance is included on the resources page. Here are the links with more information on pneumococcal testing resources. We rely on your help to conduct national surveillance for IPD, to estimate disease burden, understand the impact of current pneumococcal vaccines, plan for future vaccines, and monitor antimicrobial resistance. Thank you for your time and attention.
Thank you, Ryan, for your presentation on invasive pneumococcal disease. Joining us remotely is Stephanie Gretsch. She is a senior epidemiologist at the Chicago Department of Public Health and will be sharing experiences related to invasive pneumococcal disease.
Thank you, Dr. Rose. On February 13, 2024, we at the Chicago Department of Public Health were notified of a case of invasive pneumococcal disease, or IPD, in a 4-year-old child. This child, who had no underlying medical conditions, had a 7-day history of upper respiratory illness with a positive influenza B test on February 7th. On February 11th, the child presented to a local hospital with acute respiratory failure, likely due to secondary bacterial pneumonia. They required supplemental oxygen and fluid resuscitation and were admitted to the pediatric intensive care unit. A blood specimen was collected on the day of admission, and Streptococcus pneumoniae was isolated from culture 2 days later. The child required ongoing hospitalization and was discharged on February 27th. The child's physician became concerned about possible pneumococcal vaccine failure because the child was up to date with their pneumococcal vaccinations based on their medical record. To determine if this was indeed a vaccine failure, isolate must be serotyped, and a full pneumococcal vaccination history needs to be verified. While IPD in children younger than 5 years of age is a reportable disease in Illinois, isolates are not required to be submitted to the public health laboratory. In this case, we worked with the hospital's infection control team and laboratory to facilitate specimen submission of this isolate to a public health laboratory for additional characterization. For serotyping, the isolate was sent to an antibiotic resistance laboratory network, or ARLN laboratory. 2 ARLN laboratories are designated as Streptococcus reference centers that conduct serotyping and antimicrobial susceptibility testing for IPD isolates that meet certain criteria, including cases of potential vaccine failure. The isolate was first submitted to the Illinois Public Health Laboratory in Chicago. It was then forwarded to the Wisconsin State Laboratory of Hygiene, which is the designated laboratory for our jurisdiction. Serotyping results are usually available within 10 business days after receipt. While awaiting testing results, we reviewed the child's vaccination records in the Illinois State Immunization Registry. We verified the child was up to date and had been given 4 doses of the 13-valent pneumococcal conjugate vaccine at ages 2, 4, 6, and 17 months. We received serotyping results from the Wisconsin laboratory the following month. The child had been infected with serotype 16F, which is not covered by the 13-valent pneumococcal conjugate vaccine. We concluded that this was not a vaccine failure and shared this information back to the requesting physician. The case's clinical information, pneumococcal serotype, and vaccination history were entered into the Illinois State Disease Surveillance System, which sends de-identified case information to CDC for national surveillance. Complete ascertainment of vaccination history, along with pneumococcal serotyping, allows us to monitor local trends in circulating serotypes and communicate with clinical partners when vaccine failures occur. These data also contribute to national surveillance efforts to monitor vaccine effectiveness and trends in circulating serotypes in the United States.
Thank you, Stephanie, for that presentation. At this time, we will discuss Haemophilus influenzae type B, presented by Jennifer Collins. Dr. Collins is a medical epidemiologist with the Division of Bacterial Diseases for the National Center for Immunization and Respiratory Diseases at CDC.
Thank you, Dr. Rose. I appreciate the opportunity to discuss Haemophilus influenzae type B. Haemophilus influenzae type B, or Hib, was the most common cause of bacterial meningitis in young children in the United States before effective vaccines substantially reduced its incidence. Although invasive Hib disease is now relatively uncommon, other types of Haemophilus influenzae continue to cause a substantial burden of disease. The bacterium Haemophilus influenzae can be either encapsulated or unencapsulated. The polysaccharide capsule has 6 antigenically distinct types, designated by the letters A through F. Unencapsulated strains are referred to as non-typable. Invasive Haemophilus influenzae disease includes several clinical syndromes, including bacteremia, meningitis, epiglottitis, cellulitis, septic arthritis, and pneumonia. Non-invasive Haemophilus influenzae disease includes ear infections and bronchitis. In the pre-vaccine era, before 1990, nearly all invasive Haemophilus influenzae disease was caused by serotype B. An estimated 20,000 cases of invasive Hib disease occurred annually among U.S. children younger than 5 years of age. Hib was the leading cause of bacterial meningitis among children in that same age group. Following vaccine introduction, 20 to 40 cases of invasive Hib disease are reported each year among U.S. children under 5 years of age. This graph shows the incidence of invasive Haemophilus influenzae disease among U.S. children younger than 5 years of age since 1990, with serotype B in orange, non-B serotypes in blue, and non-typable strains in gray. The incidence of invasive Hib disease rapidly decreased by more than 99% after introduction of conjugate vaccines. Cases are confirmed through identification of Haemophilus influenzae from a normally sterile site, either through culture for the isolation of Haemophilus influenzae, or through polymerase chain reaction, or PCR, for the detection of Haemophilus influenzae specific nucleic acid. Serotyping is an extremely important laboratory procedure that should be performed for every case of invasive disease. Although PCR is increasingly being used for the diagnosis of Haemophilus influenzae, not all PCR assays can detect and differentiate Haemophilus influenzae serotypes. Thus, laboratories performing PCR are encouraged to also perform culture or to save clinical specimens for further testing. Serotyping is the only way to determine if an isolate is serotype B. This is important because serotype B is the only serotype preventable by vaccination, and chemoprophylaxis is only recommended for close contacts of persons with serotype B disease. Serotype B disease occurring in a vaccinated person may prompt additional evaluation of the person's immune system. Laboratory support for Haemophilus influenzae serotyping is available through state public health laboratories. For advice on serotyping capability within your state, contact your state health department. This slide shows information to collect during an invasive Haemophilus influenzae disease case investigation based on laboratory, hospital, and other clinical records. This includes demographic information and relevant clinical data, such as the clinical syndrome, dates of hospitalization, and outcome of the illness. Results of laboratory testing are important, including the serotype, specimen source, date of first positive culture, and antibiotic susceptibility testing results. Vaccination status should be obtained for every case caused by Hib or an unknown serotype, including date of administration, manufacturer, and lot number of each Hib vaccine dose. Finally, information is needed on risk factors for Hib disease. One of the most important considerations is whether a child attended childcare, as control measures may be needed for other attendees. Collecting information regarding the patient's race and ethnicity is important, as American Indian and Alaska Native individuals are at highest risk of developing invasive Hib disease. Once invasive Hib disease has been diagnosed, the implementation of control measures is important to reduce the risk of secondary invasive Hib infection in close contacts of the affected person. Rifampin chemoprophylaxis is recommended for all household contacts if the household has at least one member aged less than 4 years who is not fully vaccinated, or at least one member aged less than 18 years who is immunocompromised, regardless of vaccination status. Rifampin is also recommended for childcare contexts, regardless of age and vaccination status, when 2 or more cases of invasive Hib disease have occurred within 60 days and when unimmunized or underimmunized children attend the facility. Finally, rifampin is recommended for index patients who are treated with an antibiotic other than ceftriaxone or cefotaxime and who are aged less than 2 years. For cases of invasive Haemophilus influenzae type A disease, the American Academy of Pediatrics Red Book states clinicians may consider using a similar chemoprophylaxis approach as for invasive Hib disease. CDC does not have the same recommendation. It is critical that all cases of invasive Haemophilus influenzae disease are investigated, confirmed, serotyped, and reported, and that control measures are implemented in the setting of invasive Hib disease.
Thank you, Dr. Collins. This concludes the Haemophilus influenzae type B section of this training. We will now be joined remotely by Michelle Hughes to discuss tetanus. Dr. Hughes is an epidemiologist with the Division of Bacterial Diseases for the National Center for Immunization and Respiratory Diseases at CDC.
Thank you, Dr. Rose. I appreciate the opportunity to discuss tetanus during this update. Tetanus is caused by the spore-forming bacterium Clostridium tetani that is common in the environment, including in soil, dust, and manure. C. tetani bacteria enter the body, germinate, and produce a potent toxin called tetanospasmin. Tetanus is uncommon, but when it occurs, it is an acute, potentially fatal disease characterized by generalized rigidity, convulsive spasms of skeletal muscles, and trismus or lockjaw. Tetanus is not transmitted from person to person and doesn't have outbreak potential. In the United States, reported mortality due to tetanus has declined by more than 99% since the early 1900s, and documented tetanus incidence has declined by approximately 99% since 1947, when national reporting of tetanus cases began. Over the recent 10-year period from 2013 to 2022, an average of 27 cases and 1 death occurred each year. The highest instance occurred among people older than 80 years, and all tetanus-related deaths occurred among patients older than age 60 years. Currently, there are 7 licensed vaccines containing tetanus toxoid available in the U.S. for children less than 7 years, all of which are combination vaccines that also protect against diphtheria and pertussis, which we will refer to as DTaP, the capital D, T, and P. Some also protect against polio, hepatitis B, or Haemophilus influenza type B. There are also 3 vaccines licensed for use for older children, adolescents, and adults, one of which also protects against diphtheria, known as TD, or capital T, lowercase d, and 2 of which also protect against diphtheria and pertussis, known as Tdap. Adolescent and adult versions of the vaccines have reduced quantities of pertussis and diphtheria components compared with the pediatric formulations, thus the use of the lowercase letters. The Advisory Committee on Immunization Practices, or ACIP, routinely recommends a 5-dose DTaP vaccine series for all children beginning at 2 months of age through 6 years of age. A single dose of Tdap vaccine is recommended for all adolescents, with preferred administration at 11 to 12 years. After receipt of Tdap, people should continue to receive TD or Tdap for routine booster vaccination against tetanus and diphtheria every 10 years. Tetanus vaccines are very effective at protecting against tetanus, with a greater than 99% seroprotection rate after the primary series. Nearly all U.S. tetanus cases today are among adults who either never received a tetanus vaccine or didn't stay up to date with their 10-year tetanus booster shots. Other risk factors for tetanus include being 70 years or older, having diabetes, immunosuppression, and using intravenous drugs. Tetanus is a clinical syndrome. The diagnosis of tetanus is based on a clinical presentation consistent with tetanus in the absence of an alternative or more likely cause. There are no diagnostic tests that can support or rule out tetanus. Culture can lead to both false positive and false negative results. Serologic studies can't reliably evaluate individual level tetanus immunity. Tetanus treatment often involves several types of medications and supportive care. Medical experts recommend a single 500 international unit dose of human tetanus immune globulin, or TIG, for tetanus treatment. TIG is commercially available and not stockpiled or released by CDC. TIG helps remove unbound tetanus toxin from the body. It cannot affect toxin already bound to nerve endings. In addition to TIG, clinicians should monitor and maintain an airway, depending on disease severity, control muscle spasms, manage wounds, and treat infections, and provide antimicrobial therapy to reduce the number of bacteria. For reporting purposes, according to the 2010 Council of State and Territorial Epidemiologists definition, a probable case is defined as follows. In the absence of a more likely diagnosis, an acute illness with muscle spasms or hypertonia, and a diagnosis of tetanus by a healthcare provider, or death with tetanus listed on the death certificate as the cause of death or a significant condition contributing to death. There is no case definition for confirmed tetanus. Once tetanus is suspected, gathering detailed information about the case is important. The case investigation should include collecting the epidemiologic information on the CDC Tetanus Surveillance Worksheet, or Appendix 18. As tetanus is a rare disease, all efforts should be made to complete the full epidemiologic information in Appendix 18 for each case. However, there are certain key information that should be completed for every reported tetanus case beyond the standard demographic data included for all reportable diseases, including tetanus vaccination history, including years since the last dose, whether an acute wound was identified, and if so, the principal wound type, what medical care was provided before disease onset, including whether the patient was given tetanus toxoid vaccine or had their wound treated. If there was no acute wound, whether they had an underlying contributing condition, including whether they have a history of diabetes or parenteral drug abuse, the clinical course of the tetanus disease and whether it resulted in death, which may require follow-up longer than 1 month. Lastly, if the case is a neonate, information should be gathered on the mother's age, mother's tetanus vaccination history, including years since the last dose, and child's birthplace. Even though tetanus is rare in the United States, continued surveillance is critical given the increased risk for severe disease and death.
Thank you, Dr. Hughes. This concludes the tetanus section of this training. We will now be joined by Amy Rubis to discuss pertussis. Mrs. Rubis is an epidemiologist with the Division of Bacterial Diseases for the National Center for Immunization and Respiratory Diseases at CDC.
Thank you, Dr. Rose. High vaccination coverage has led to all-time record low levels of many vaccine-preventable diseases, but not pertussis. Pertussis remains endemic in the United States. Sporadic cases and community-wide transmission continue to occur in spite of high vaccine coverage among children and adolescents. Pertussis, or whooping cough, is caused by the bacterium Bordetella pertussis. Classic pertussis illness is characterized by severe paroxysmal coughing, sometimes followed by an inspiratory whoop. Illness can be milder and the typical whoop absent, especially in those who have been vaccinated. Pertussis occurs in a cyclical pattern, with the number of cases peaking every few years as immunity within the population wanes. Before a vaccine was available, pertussis was a universal infection of childhood, with hundreds of thousands of cases each year. After the introduction of the whole cell pertussis vaccine in the late 1940s, indicated here on the graph, the number of reported cases began to drop. Because of concerns about the safety of whole cell vaccines, the U.S. transitioned to acellular pertussis vaccines during the 1990s. In 2005, Tdap booster vaccines were recommended for adolescents and adults. Since the late 1980s, the number of reported cases of pertussis in the United States has been gradually rising, and significant peaks in disease have been observed in recent years, seen here in the inset. In 2012, more than 48,000 cases were reported. Multiple factors have likely contributed to this increase, including changes in diagnostic testing and reporting, increased provider awareness, and waning of vaccine-induced immunity. Waning immunity from acellular vaccines is likely the primary driver of this increase. Reported cases decreased substantially during the COVID-19 pandemic, but are now returning to levels observed before the pandemic. Historically, pertussis was considered a disease of young children. However, a significant proportion of reported pertussis now occurs among older children, adolescents, and adults. Although infants typically have the most severe cases of pertussis, older children and adolescents can also have severe illness. Waning immunity from acellular vaccines means fully vaccinated people, both adolescents and adults, will get pertussis, though generally will have milder disease and suffer fewer complications compared to vaccinated people. While the majority of reported cases are in children and adolescents, incidence is highest in infants younger than 1 year of age, shown in the green line here. Despite the increase in reported pertussis cases since the 1980s, pertussis deaths remain rare. Historically, most pertussis deaths occur among infants younger than 2 months of age who are too young to be vaccinated. As you can see here, the number of pertussis deaths has declined in the U.S., especially among young infants, which may be in part due to the introduction of maternal vaccination during pregnancy. There are currently 7 diphtheria, tetanus, and acellular pertussis vaccines licensed in the United States for use in infants and children through 6 years of age. The pediatric vaccines are referred to as DTaP. Some of these vaccines are available in combination with other vaccines. There are also 2 acellular pertussis vaccines approved for use in adolescents and adults. These vaccines are also combined with diphtheria and tetanus toxoids and are referred to as Tdap. The pediatric vaccines are different from the adolescent and adult vaccines. Adolescent and adult versions of the vaccine have reduced quantities of pertussis components compared with the pediatric formulations. Pertussis vaccines continue to be the best way to protect people from pertussis and its complications. ACIP routinely recommends a 5-dose DTaP vaccine series for all children beginning at 2 months of age through 6 years of age. The first dose may be administered as early as 6 weeks of age. A single dose of Tdap vaccine is recommended for all adolescents, with the preferred administration at 11 to 12 years of age. Adults who did not receive Tdap as an adolescent are recommended to receive a single dose of Tdap as soon as possible. Immunity to pertussis wanes after a few years. However, there's no ACIP recommendation to give booster doses to maintain pertussis immunity. Adults do need doses every 10 years to maintain protection against diphtheria and tetanus. Although these doses are aimed to protect against diphtheria and tetanus, either TD or Tdap can be given for these doses. Also, pregnant women should be vaccinated during the 3rd or late 2nd trimester of every pregnancy, preferably during the early part of gestational weeks 27 through 36, even if they've received Tdap previously. This helps protect infants during the critical time between birth and 2 months of age when they are not old enough to begin getting their own pertussis vaccines. Pertussis should be suspected in persons with cough illness lasting more than 7 days, with coughing fits, inspiratory whoop, or a cough that induces vomiting. Cough is typically the hallmark of pertussis, but very young infants with pertussis may present with apnea or long pauses in breathing with little to no cough present. When pertussis is clinically suspected, appropriate specimens should be obtained for laboratory testing. For national case notification, there are 2 different methods by which cases can be laboratory confirmed. These methods are isolation of Bordetella pertussis from a clinical specimen or a positive PCR test. Commercial serologic tests for pertussis infection are not standardized, therefore results of serologic testing are not used for case confirmation for national reporting. Culture of a nasopharyngeal specimen is considered the gold standard for diagnosis. Optimal timing for diagnosing pertussis using culture is within 2 weeks of cough onset. While culture is highly specific, sensitivity declines when patients have received antibiotics, have been recently vaccinated, or when there are delays in specimen collection. Culture results may not be available for 7 to 14 days, but despite this delay, it is important to still try to collect culture specimens for pertussis patients, especially in the setting of an outbreak. PCR is the most commonly used method for diagnosing pertussis and is optimally sensitive less than 3 weeks after cough onset. PCR is a sensitive and timely diagnostic tool, but its use should be limited to diagnose patients who have developed pertussis-like symptoms. A nasopharyngeal swab or aspirate is the preferred method of obtaining a specimen for pertussis culture and PCR. Laboratory results are an important part of an investigation of a suspected case of pertussis, but there is other information you will need to collect as well. As always, demographic information like age is important to collect, as well as clinical data, such as the duration of cough, presence of paroxysms, whoop, and post-tussive vomiting. This information is important because laboratory testing cannot always be obtained or may not be conclusive. The clinical data can be used to determine if the person has met the clinical case definition for pertussis reporting. In addition, it's important to know how severe the illness is, including complications like pneumonia and whether or not the patient survived. And of course, knowing the vaccination history is critical. A complete vaccination history includes the date, vaccine type, and manufacturer for each dose of vaccine. This is important for all cases now that vaccines are recommended for all ages. In light of the recommendation for Tdap administration during pregnancy, public health personnel will want to collect Tdap history for mothers of infant pertussis cases less than 1 year of age. A pertussis surveillance worksheet is included in the Manual for Surveillance of VPDs. This worksheet will help you organize your case investigation so you will not miss any critical information. Understanding the appropriate application of post-exposure prophylaxis, or PEP, for contacts of pertussis cases is also important for clinicians and public health professionals. CDC supports targeted PEP for contacts of pertussis cases who are at greatest risk for infection and severe pertussis. This includes household members, infants, pregnant women, and people with certain underlying health conditions. PEP should also be considered for contacts who themselves have close contact with high-risk individuals. More detailed information about PEP for pertussis may be found on the CDC pertussis website shown on the slide. With the ongoing resurgence of pertussis in the United States, as well as the recommendations for Tdap administration among pregnant women, surveillance will be essential to monitor changes in pertussis epidemiology and the impact of the current pertussis prevention and control strategies. Thank you.
Thank you, Amy. This concludes the pertussis section of this training. At this time, we will be joined remotely by Erin Tromble to discuss diphtheria. Dr. Tromble is a medical epidemiologist who serves as the team lead for diphtheria, pertussis, and tetanus epidemiology for the National Center for Immunization and Respiratory Diseases at CDC.
Thank you, Dr. Rose. We will now begin with the diphtheria section of this update. Diphtheria is caused by diphtheria toxin, which is produced by certain strains of Corynebacterium diphtheriae. Important sites of infection include the respiratory mucosa, which may lead to respiratory diphtheria, and the skin, which may lead to cutaneous diphtheria. The hallmark of respiratory diphtheria is the presence of a tough, grayish-white pseudomembrane over the tonsils, the pharynx, or larynx. The pseudomembrane may progressively extend into the larynx and trachea and cause airway obstruction, which, if left untreated, can be fatal. Cutaneous diphtheria is usually mild, typically consisting of sores or shallow ulcers. The disease is transmitted from person to person by respiratory droplets or direct contact with respiratory secretions or discharge from skin lesions. Prior to 2019, only respiratory diphtheria was reportable in the US. However, given that cutaneous and other forms of non-respiratory diphtheria can be transmitted and cause respiratory diphtheria, the US case definition was revised in 2019 to include disease caused by toxin-producing C. diphtheriae from any site, including cutaneous sites. A suspect case is an upper respiratory tract illness with an adherent membrane of the nose, pharynx, tonsils, or larynx, and absence of laboratory confirmation and lack of epidemiologic linkage to a laboratory-confirmed case of diphtheria, or histopathologic diagnosis, all in the absence of a more likely diagnosis. A confirmed case is an upper respiratory tract illness with an adherent membrane of the nose, pharynx, tonsils, or larynx, and any of the following: isolation of toxin-producing C. diphtheriae from the nose or throat, or an epidemiologic link to a laboratory-confirmed case of diphtheria, or an infection at a non-respiratory anatomic site, for example, skin, wound, conjunctiva, ear, genital mucosa, with isolation of toxin-producing C. diphtheriae from that site. Diphtheria toxoid is a vaccine that protects against diphtheria. It is only available in combination with other vaccines. Currently, there are 6 vaccines with diphtheria toxoid that are licensed in the United States for use in infants and children less than 7 years of age. There are also diphtheria toxoid vaccines approved for use in adolescents and adults. 2 of these vaccines protect against tetanus and pertussis as well. Adolescent and adult versions of the vaccines have reduced quantities of pertussis and diphtheria components compared to the pediatric formulations, thus the use of lowercase letters. Before the introduction of diphtheria toxoid vaccines, the number of diphtheria cases in the United States exceeded 200,000 in some years, as shown in this graph. With attainment of high vaccination coverage, the number of cases declined dramatically. For example, from 1980 through 1995, 41 respiratory diphtheria cases, including 4 fatal cases, were reported in the United States. From 1996 to 2015, only 13 cases of respiratory diphtheria were reported, including 1 fatality, and no confirmed respiratory cases have been reported in the United States since 2016. However, since 2016, there's been a substantial increase in the number of C. diphtheriae infections in the US, resulting in a 5-fold increase in C. diphtheriae isolates submitted to CDC between 2019 and 2023. This recent trend can cause confusion and has raised some questions among community members and providers about whether vaccines are failing, coverage is dropping, or something else is going on. Answering these questions requires a bit of background on C. diphtheriae and diphtheria toxin. Unlike some toxin-producing bacteria, not all strains of C. diphtheriae produce diphtheria toxin. C. diphtheriae doesn't naturally possess the gene called tox that encodes diphtheria toxin. Instead, tox is encoded by a virus called a phage that's capable of infecting some cyanobacteria. Only C. diphtheriae that have been infected with the phage or are descended from a bacteria that was previously infected are potentially capable of producing diphtheria toxin and being toxigenic. Unaffected strains are non-toxigenic. It's essential to understand that diphtheria and the symptoms associated with diphtheria, like pseudomembrane, are caused by diphtheria toxin, not C. diphtheriae bacteria. Importantly, it's this diphtheria toxin that diphtheria vaccines provide antibodies against, not C. diphtheriae bacteria. This means fully vaccinated people can have C. diphtheriae infection, including with the toxigenic strain, without developing diphtheria because the vaccine protects them against diphtheria toxin. So simply put, diphtheria is a vaccine-preventable disease. C. diphtheriae infection is not. Additionally, toxin-producing strains of C. diphtheriae are no longer endemic in the US, and the overwhelming majority, 99.9%, of infections we see don't produce toxin. All of this means that while C. diphtheria infection is on the rise in the US, diphtheria is not. As this figure shows, only a tiny fraction of C. diphtheria infections detected since 2016 have been toxigenic. However, it is still critical to understand whether a C. diphtheria infection is caused by a toxin-producing strain because there are important differences in public health action and treatment recommendations. Determining which type of infection is present requires laboratory confirmation. Healthcare providers and public health personnel should suspect diphtheria in an ill patient if an adherent membrane is present in the nose or throat, and a specimen should be collected from beneath the membrane or a piece of membrane whenever possible. Preliminary tests that may support a diphtheria diagnosis include gram strain or large dominant colonies of gram-negative rods on culture. Although historically, specialized media like Tinsdale or Loeffler's media were required to isolate and identify C. diphtheriae, the development and increased use of MALDI-TOF, which is a specialized mass spectrometry, means many clinical labs are now able to identify C. diphtheria using standard non-selective media. However, as we discussed, the presence of C. diphtheria alone does not diagnose diphtheria. Confirmation of diphtheria requires testing for the presence of diphtheria toxin through the modified ELIC test. A few state public health labs have implemented PCR testing that can identify the tox gene. However, this test also does not confirm whether the organism is producing the toxin. Some strains of C. diphtheriae have mutations in the tox gene and don't produce diphtheria toxin. So PCR is useful for ruling diphtheria out, but does not rule it in. Because of the number of diagnostic steps required, confirmatory diphtheria testing can take several weeks. But clinical and public health decision-making are often necessary before this. Risk stratification can help determine which suspect cases should be immediately investigated and which can wait for confirmatory testing. First, anytime there are clinical findings consistent with toxin-mediated disease, such as pseudomembrane, bull neck, cardiomyopathy, or neuritis, these findings suggest diphtheria toxin may be causing illness and should prompt an immediate investigation of both cases and contacts. Additionally, because toxin-producing strains of C. diphtheriae aren't endemic in the U.S., recent travel to a country with endemic or epidemic diphtheria is another key risk factor. If there is a travel history, even in the absence of symptoms of diphtheria toxin, you may want to consider starting a full case and contact investigation. The mainstay of diphtheria treatment is diphtheria antitoxin. This should be given early when toxin-mediated symptoms are present. A licensed diphtheria antitoxin product is no longer available in the United States. However, diphtheria antitoxin under an investigational new drug protocol is available from CDC. Healthcare providers may request this directly from CDC after discussing the need for antitoxin with their respective state health departments. Even though diphtheria is rare in the United States, continued surveillance is critical given the increased risk for severe disease and death.
Thank you, Dr. Tromble. This concludes the diphtheria section of the training. At this time, we will be joined remotely by Sandy Rausch to discuss surveillance indicators. Mrs. Rausch is the Associate Director for Surveillance for the National Center for Immunization and Respiratory Diseases at CDC.
Thank you, Dr. Rose. We rely on public health surveillance to monitor the effectiveness of our immunization programs. But how can we monitor the effectiveness or quality of our surveillance? Surveillance is the challenge when disease for which we're doing surveillance is rare. How do we know whether no cases were reported because there really were no cases or because no one was looking? We rely on surveillance indicators to monitor the quality of national public health surveillance for vaccine-preventable diseases. Certain critical elements need to be collected during investigation of cases of vaccine-preventable diseases. These include demographic information, relevant clinical and laboratory data, and vaccination status. Monitoring whether or not these data are reported lets us track the quality of case investigation, and we do this routinely. But that does not tell us whether or not 0 cases reported really means 0 disease or infection. We must ensure that we can identify and respond to every case when disease rates are very low. National public health surveillance traditionally relies on passive reporting, which is often incomplete. In spite of this limitation, data from passive reporting are useful for routine national surveillance because those data are used primarily for monitoring trends in disease occurrence rather than in response to individual cases. However, for diseases with very few remaining cases, as with most of the vaccine-preventable diseases, surveillance data must be very complete. Every case counts. We need to know that 0 reported cases really means that there is actually no disease. Surveillance indicators have been developed to assess the quality of national surveillance for vaccine-preventable diseases. Specifically, the indicators can assess the completeness of reporting. Remember that surveillance must also be specific enough to exclude non-cases by adequate case investigation and laboratory testing. Surveillance indicators can also be used to assess investigative effort and the completeness of epidemiologically important surveillance data. Methods to monitor surveillance quality were first developed in 1988 by the Pan American Health Organization as part of the polio eradication effort in the Western Hemisphere. Surveillance indicators for measles, mumps, and rubella are very similar to each other. The indicators include completeness of data, timeliness of reporting, proportion of cases that are laboratory confirmed, and proportion of cases that have an imported source. If our surveillance system can identify even imported cases of measles and rubella, for example, we have confidence that the system could also identify indigenous cases if they were present. For measles, we measure the proportion of cases for which a clinical specimen is submitted for virus isolation. For rubella, we also measure the proportion of cases among women of childbearing age with known pregnancy status. We have also developed surveillance indicators for Haemophilus influenza, Pertussis, varicella, meningococcal disease, and invasive pneumococcal disease. For Haemophilus influenza, we measure the timeliness and completeness of case information for children younger than 5 years of age, including vaccine history and serotype. We can also track the incidence of non-type B disease among children younger than 5 years of age. For pertussis, we measure timeliness and completeness of epidemiologic data, especially vaccination history for children younger than 7 years of age. We also look at the proportion of clinically compatible cases that have laboratory testing. For varicella, we measure the completeness of epidemiologic data, focusing on the proportion of cases with laboratory testing and cases with complete vaccination history. In addition, the proportion of cases related to outbreaks is an important component of varicella surveillance. For meningococcal disease, we measure completeness of epidemiologic data, especially vaccination history and clinical outcome. We also look at the proportion of cases that have serogroup testing. For invasive pneumococcal disease, we measure completeness of epidemiologic data, especially vaccination history and isolate serotyping. I appreciate this opportunity to describe a few approaches to monitoring the quality of public health surveillance for vaccine-preventable diseases. To summarize, we do surveillance to monitor the quality of our immunization program, and we use surveillance indicators to monitor the quality of that surveillance. With the incidence of many of the vaccine-preventable diseases at very low levels, we cannot be sure that 0 means 0 unless we can document that we can find cases if they exist.
Thank you, Sandy. That concludes this section of the training. I want to provide a reminder of a few surveillance-related resources that are available. First, the Manual for the Surveillance of Vaccine-Preventable Diseases, which includes chapters that provide a quick reference for information that would support public health surveillance for VPDs. It's available at the CDC website at the link shown here on the slide. Secondly, the VPD reference centers are those 4 public health laboratories that were mentioned earlier. The information about the reference centers can be found on the web address shown on this slide. Third, the link to the NNDSS webpage that contains the public health case definitions for all infectious conditions under national public health surveillance is included on this slide as well. Additionally, there is a video available that shows the proper technique for collection of a nasopharyngeal swab for pertussis. This video is available at the web address shown here on the slide. The previously mentioned CDC PCR serotyping protocol can be found at the link here on the slide in the second bullet. We certainly do hope that you find these resources helpful. In support of improving patient care, the Centers for Disease Control and Prevention is jointly accredited by the Accreditation Council for Continuing Medical Education ACCME, the Accreditation Council for Pharmacy Education, ACPE, and the American Nurses Credentialing Center, ANCC, to provide continuing education for the healthcare team. The specifics regarding continuing education accreditation for this session are presented on this slide. For this session, you can see that there are 1.5 CME credits available, 1.5 CNE credits, 0.2 CEU credits, and 2.0 CPH credits available. For those seeking continuing education credits, we have the following instructions. To receive continuing education credits for this session, activity number WD-489-020425-2025 CDC Training for Bacterial Vaccine-Preventable Disease Surveillance. 1. Pass the post-assessment at 80%. 2. Complete the evaluation. 3. Visit Your Learning to access your certificates and transcript. At this time, we have a few minutes to discuss some questions that we have received related to bacterial vaccine-preventable disease surveillance. I'm rejoined by Amy Rubis to discuss meningococcal disease and pertussis. Our first question is related to meningococcal disease. Amy, is decreased vaccination coverage during the pandemic causing the increase in meningococcal disease cases?
No, the increase in meningococcal disease cases is being driven primarily by serogroup Y sequence type 1466, and the majority of those cases are 30 to 60 years of age. This age group is not routinely recommended to receive meningococcal vaccine.
For public health awareness, what influences the likelihood of developing meningococcal disease?
The risk factors that influence the development of meningococcal disease fall into three broad categories. The first is pathogen virulence factors, including the polysaccharide capsule mentioned earlier in the session. There are also host factors that affect whether someone develops invasive disease. People with complement deficiencies, people who are asplenic, and people with HIV are at a higher risk for meningococcal disease. And finally, there are population and environmental factors that influence risk, including factors that increase exposure and factors that influence the health of the nasopharynx and the body's ability to prevent invasion, like active or passive smoking and having an upper respiratory tract infection.
Based on preliminary data so far, did the number of meningococcal disease cases increase during 2024?
Yes, we did see an increase in meningococcal disease in 2024 due to both serogroup Y sequence type 1466 cases and ciprofloxacin-resistant cases. We are asking that health departments continue to submit isolates to CDC as part of enhanced surveillance to monitor for ciprofloxacin resistance and to inform potential changes to prophylaxis.
Going back to your presentation, the last slide of the training mentions risk factors. What risk factor data is collected through meningococcal disease surveillance?
As part of enhanced meningococcal disease surveillance, we ask that health departments collect information on whether the case was part of a meningococcal disease outbreak. In addition, the investigation should collect epidemiologically important information to inform public health.
I would now like to ask about your presentation on pertussis. Based on preliminary data so far, did the number of pertussis cases increase during 2024?
Yes, we saw reported pertussis cases increase across the U.S. in 2024, indicating a return to more typical trends following the COVID-19 pandemic. The number of reported cases in 2024 was higher than what was seen in 2019 prior to the pandemic. However, this was not unexpected. Pertussis is cyclical, and we typically see peaks in disease every 3 to 5 years. We understand that the COVID-19 pandemic interrupted typical whooping cough patterns.
Please summarize the current CDC guidance for pertussis surveillance. When should pertussis be suspected, and how is it laboratory confirmed?
Pertussis should be suspected in persons with cough illness lasting more than 7 days with coughing fits, inspiratory whoop, or a cough that induces vomiting. Cough is typically the hallmark of pertussis, but very young infants with pertussis may present with apnea or long pauses in breathing with little to no cough present. When pertussis is clinically suspected, appropriate specimens should be obtained for laboratory testing. For national case notification, there are two methods by which cases can be laboratory confirmed. These methods are isolation of Bordetella pertussis from a clinical specimen or a positive PCR test. Commercial serologic tests for pertussis are not standardized, and therefore results of serologic testing are not used for case confirmation for national reporting.
In conducting surveillance, what demographic and clinical information should be collected for pertussis cases?
Demographic information like age is important to collect, as well as clinical data such as the duration of cough and the presence of paroxysms, whoop, and post-tussive vomiting. This information is important because laboratory testing cannot always be obtained or may not be conclusive. The clinical data can be used to determine if the person has met the clinical case definition for pertussis reporting. In addition, it's important to know how severe the illness is, including complications like pneumonia and whether or not the patient survived. And of course, knowing the vaccination history is critical.
Looking at data for the past few years, did decreased vaccination coverage during the pandemic cause the increase in pertussis cases?
No, pertussis vaccination coverage has remained stable in recent years. As we return to our typical infection patterns, we expect pertussis cases to increase both in unvaccinated and vaccinated populations. Similar to before the pandemic, we do expect to see cases in fully vaccinated individuals due to waning immunity from acellular vaccines. But vaccinated individuals will typically have milder disease.
Thank you so much to Ms. Rubis for answering questions related to meningococcal disease and pertussis. I will now respond to some questions we received related to diphtheria. Considering surveillance guidance, when should a case and contact investigation be initiated for suspect diphtheria cases? If a suspect case has clinical symptoms consistent with toxin-mediated disease, such as pseudomembrane, bull neck, cardiomyopathy, or neuritis, a case and contact investigation should be started immediately. We've gotten a number of questions on testing. Is testing for the presence of diphtheria toxin via ELIC testing the only way to confirm diphtheria? Yes. Testing for the presence of diphtheria toxin via ELIC testing is the only way to confirm diphtheria. However, MALDI-TOF can be used as a preliminary test to identify C. diphtheriae in many labs. Looking at the historical trends, have both C. diphtheriae infections and diphtheria increased in the U.S.? Although C. diphtheriae infections have recently increased in the U.S., diphtheria has not. Remember that prior to 2019, only respiratory diphtheria was reportable in the U.S. However, given that cutaneous and other forms of non-respiratory diphtheria can be transmitted and cause respiratory diphtheria, the U.S. case definition was revised in 2019 to include disease caused by toxin-producing C. diphtheriae from any site, including cutaneous sites. Can you clarify the recent trend in the increase in the number of C. diphtheriae infections in the U.S., resulting in a 5-fold increase in C. diphtheriae isolates submitted to CDC between 2019 and 2023? Answering this question requires a bit of background on C. diphtheriae and diphtheria toxin. Unlike some toxin-producing bacteria, not all strains of C. diphtheriae produce diphtheria toxin. C. diphtheriae doesn't naturally possess the gene called TOX that encodes diphtheria toxin. Instead, TOX is encoded by a virus called a phage that's capable of infecting some Corynebacteria. Only C. diphtheriae that have been infected with the phage or are descended from a bacteria that was previously infected are potentially capable of producing diphtheria toxin and being toxigenic. Uninfected strains are non-toxigenic. Importantly, it's this diphtheria toxin that diphtheria vaccines provide antibodies against, not C. diphtheriae bacteria. This means fully vaccinated people can have C. diphtheriae infection, including with a toxigenic strain, without developing diphtheria because the vaccine protects them against diphtheria toxin. Simply put, Diphtheria is a vaccine-preventable disease. C. diphtheria infection is not. I'm again joined by Dr. Collins to discuss questions related to Haemophilus influenzae. I have a multi-part question for you. Should everyone with Haemophilus influenzae be serotyped? What kind of specimen does that require? And where do I send the specimen?
Every case of Haemophilus influenzae invasive disease should be serotyped, and in particular, those occurring in persons younger than 15 years of age. Clinical specimens from normally sterile sites should be used. Contact your state health department to determine availability of serotyping at the state public health laboratory.
Dr. Collins, does the CDC know what is driving the increase in non-typable Haemophilus influenzae cases since 2021?
We are not sure. Notably, given that 2023 data are preliminary, we are not yet sure whether this is a meaningful increase versus general noise in the data. If it is a true increase, a few possibilities exist. Cases could be rebounding because young children did not have as much exposure to non-typable Haemophilus influenzae during the COVID-19 pandemic. Additionally, we are aware of strains of non-typable Haemophilus influenzae that seem to be unusually virulent. For example, sequence type 1714 caused an outbreak in an elementary school in Detroit and has also caused a cluster of cases in the Atlanta area.
Here's a short answer question for you. Do Haemophilus influenzae type B, or Hib, vaccines provide any cross-protection against other serotypes of non-typable Haemophilus influenzae?
No, Hib vaccines only provide protection against type B.
Considering data collection related to surveillance for Haemophilus influenzae, how important is it to collect Hib vaccine manufacturer and type?
For cases caused by Hib or an unknown serotype of Haemophilus influenzae, it is very important to collect thorough Hib vaccine information, including Hib vaccine manufacturer and vaccine type. Vaccine information is important for identifying possible vaccine breakthrough cases, that is, cases occurring in children who have been vaccinated against Hib. Vaccine type is particularly important following a recent Hib vaccine policy change in 2024. The combination vaccine Vaxelis was included with PVax-Hib in the preferential recommendation for American Indian and Alaska Native infants based on the Hib component. Although Vaxelis is anticipated to be as effective as PVax-Hib at preventing invasive Hib disease in American Indian and Alaska Native infants, collecting Hib vaccine type is important to monitor for possible breakthrough cases.
Thank you so much to Dr. Collins for answering questions related to Haemophilus influenzae. I will now discuss some questions we received related to tetanus. What age group has the highest risk of death due to tetanus? The answer is people older than 60 years. Since 2013, all tetanus-related deaths occurred amongst this older age group. Next question. If there is a suspected case of tetanus, what laboratory test can be used to diagnose tetanus? There is no laboratory test that diagnoses or rules out a tetanus diagnosis. The diagnosis must be made entirely using clinical judgment. Tetanus diagnosis is based solely on clinical presentation consistent with tetanus in the absence of an alternative or more likely cause. CDC does not conduct or offer tetanus laboratory testing. Prompt clinical recognition of tetanus is important because hospitalization and treatment are required. About how many tetanus cases have been reported in the U.S. each year in the last decade? An average of 27 cases of tetanus per year have been reported in the U.S. since 2013. I will now review some questions related to invasive pneumococcal disease, or IPD. How many cases of invasive pneumococcal disease are there in the United States each year? In the United States, there are an estimated 30,000 cases of IPD and 3,000 IPD deaths each year. There are over 100 distinct serotypes of Streptococcus pneumoniae. However, serotypes vary in their ability to cause disease. A number of our audience have asked, what are the two surveillance systems for IPD in the United States? One platform is CDC's Active Bacterial Core Surveillance System, or ABCs. The other is the Nationally Notifiable Disease Surveillance System, or NNDSS. The rapid changes in IPD rates during the COVID-19 pandemic and the recent introduction of new, higher valency vaccines highlight the importance of continued IPD surveillance to monitor trends. Although ABCs provides detailed information on IPD cases from 10 areas of the United States, it cannot provide information on the impact of each state's pneumococcal conjugate vaccine program. Nationally notifiable diseases surveillance data is important for that purpose. IPD cases in people of all ages are nationally notifiable. Here's a good question about testing types. What lab tests are most important and available for IPD surveillance? It's important to serotype isolates from IPD cases. Without serotype information, it is much more difficult to determine the impact of serotype-specific pneumococcal vaccines and to identify potential serotypes for use in future vaccines. It's also valuable to obtain antimicrobial susceptibility testing, or AST, for IPD isolates to monitor antibiotic resistance. There are several options available for jurisdictions to perform serotyping and AST. State public health labs, clinical and commercial labs can use polymerase chain reaction, or PCR, for serotyping. CDC has developed a protocol to identify pneumococcal serotypes using PCR. A link to that protocol was presented earlier in this session. Phenotypic testing can be performed by Quellung, and whole genome sequencing can be used to predict serotype and antimicrobial resistance patterns. If states are unable to perform serotyping or AST, two reference laboratories, which are part of the CDC-funded Antimicrobial Resistance Laboratory Network, or ARLN, can assist states with CLIA-approved serotyping and AST for IPD isolates that meet certain criteria. Links with information on testing through ARLN were also provided earlier in this session. Additionally, CDC's Streptococcus laboratory can assist with non-CLIA serotyping of potential outbreak isolates, and AST can be performed for isolates with unusual resistance features. Thank you to our presenters for their time, and thank you all for attending the bacterial disease session of the 2025 CDC Training for Vaccine-Preventable Disease Surveillance. We hope that you find this information helpful. We will adjourn at this time.